Thank you very much for inviting me to present intraocular lens implantation in children under 2 years of age. So that's my workplace. It's a walking distance from here, Moorfield Eye Hospital, Abu Dhabi branch. So as Professor O'Keefe said, there's a consensus to operate bilateral dense congenital cataract at 6 weeks of age. But intraocular lens implantation, there are still controversies regarding the safety and complications and what lens to put in because of myopic shift. So biometry is done usually under general anesthesia in this age group. So as you know, indentation by the A-scan probe can give a false readings. So immersion technique is better to use. And the keratometry is done by handheld keratometers. So the formulas similar to adults, SRK2, SRKT, Holiday and Hoverq give quite similar results. A publication from Malaysia recommended SRK2 as a formula of choice. There are softwares available in which you can put age of the child, keratometric reading, axial length, and age at which you want the child to be emmetropized, and it can give you the results by how much reduction you need to do. So the power of the eye will depend on the age, it's bilateral. In unilateral cases, one thing is very important to do the refractive status of the other eye, because you don't want to have a big anisometropia. So we calculate it by normograms, it's by Kenneth Wright, or this one I quoted here is from American Academy. In general, it's a 20% reduction under 2 years of age, which is, suppose the reading is coming around plus 30, so reduce 6, which is 20%. So the IOL insert, it will be 24 diopters. So this publication is from last year. It's this toddler aphakia and pseudophakia study. And it has compared children implantation of IOL between 6 and 12 months compared to older age group. And there's a 4-year follow-up and no additional complication using between 6 and 12 months, inserting IOL. So that can be a practice-changing research. So there are different types of lenses. I will not go in detail because of time constraint. But in general, we use hydrophobic acrylic single-piece IOL if you're doing an in-the-bag insertion. Or if it's a sulcus insertion, then it will be hydrophobic acrylic 3-piece lenses. Multifocal IOLs in unilateral cataracts in older children has been tried. They're heparin-coated, hydrophilic, used in children with uveitis, or iris-fixated lens, usually artisan from 2 years onwards. So in case of refractive surprise or a high myopic shift or anisometropia, the secondary procedures can be done like IOL exchange. Sulcoflex IOL has been used as a piggy bag, which is a good choice. And then contact lenses, artisan lens. ICL is difficult in children because of very difficult to get a white-to-white accurate measurement, and size is a major issue. So I don't recommend this. So there are few contraindications when we should not be using intraocular lenses. Mainly it's micro-ophthalmia, which is like corneal diameter. If it's between 9 and 10, it's a relative contraindication. But less than 9 millimeter corneal diameter is an absolute contraindication to put IOL. Anterior segment dysgenesis, glaucoma, especially uncontrolled one, and uveitis, it's not recommended to put a lens because it can cause chronic inflammation. So just to end the talk, I'll present two of the cases with the video presentation. First one is 23 months old female with Malinowski-Sjogren syndrome, SL1 gene. And the two siblings got the same condition. The report is from an elder sister. She got systemic features of ataxia and motor developmental delay. So have cataract developed exactly at 2 years in all the siblings. And the father happened to be a pediatrician, so he got an ophthalmoscope and checking regularly, and all children develop at exactly the same, like just before the second birthday. So this video showing, it's a straightforward cataract. My technique like doing anterior capsulorhexis followed by automated aspiration. It's just a single port normally if it's a straightforward cataract. And after the IOL insertion, I inject viscoelastic behind the lens to create a space to do the posterior capsulotomy. So it's recommended to do posterior capsulotomy up to age of 3 or 4, and even later on if the child has a learning difficulty, or you think the capsulotomy will be difficult. And I always intracamerally give triamcinolone to check any vitreous in the anterior chamber. Sorry about the unfocused video quality is not good. And yeah, so that's the, yeah. So the case 2 is an 18 months old girl with the mother noticed the convergent squint of 8 to 9 months and not been to any ophthalmologist. And only 3 or 4 weeks back, she started noticing white reflex in the pupil. So there was no history of trauma. She was quite difficult to examine in clinic. So I noticed there's a dense cataract, white reflex, no fundus view. We did a B scan. And I suspected that there's a posterior lenticonus because of the reflection. And this is a video showing the surgery. So to my surprise, it was like the major part of the lens is in the anterior vitreous. This video is only 2 weeks old, like done recently. And the central line you're seeing is a defect in the posterior capsule. So I did anterior capsulotomy. And then using the vitrectomy cutter, I aspirated the soft lens method and done anterior vitrectomy. So I always use an AC maintainer, and it helps a lot. And after vitrectomy, an IOL was placed in the sulcus. So I'll show in a second. Yes. So it's a 3-piece hydrophobic IOL, and insertion is in the sulcus. So it was all supported by the anterior capsulotomy. Thank you. So in conclusion, take-home message is IOL insertion is safe under over 6 months of age. And it's very important in unilateral cases because IOL give superior optical correction compared to contact lens or glasses. Secondary procedures can be done in case to bring the emetropia by correcting anisometropia. Biometry is a challenge in this age group, but technology is getting better. Thank you very much.
Thank you very much, Dr. Sayed. Our next speaker is Professor Gorka Sisma, will present traumatic cataract in pediatric population. Professor Gorka, he's in pediatric division in KCASH. He has special interest in complex strabismus surgery cases and infantile and congenital cataract. Welcome.
Thanks for the invitation. I feel honored. Just 1 second. If you have the QR reader, be ready with this application. iPhone can work directly. If you try to get the picture of the QR, it's going to be captured. Let me try to see if I can give the lecture in the proper time. Traumatic cataract is a real problem. It's an important cause of preventable blindness in children. Some public prevention campaigns should be addressed. Regarding the treatment, there is no algorithm for the treatment. Dr. Agarwal in this link give us some guidelines to solve some questions about this. These questions should be answered to get the proper decision. And the decision to solve, we have a relation, high association of rupture globe and traumatic cataract occurring at the same time. The decision to solve both at the same time should be tailored. This is Bill Cinco, who created this wonderful tool. Can you use this tool for the traumatic cataract? Yes, but you should be sure that you don't have vitreous in the AC. If you suspect that you have vitreous in the AC, be prepared with the vitrector machine. If you have vitreous prolapse, never tract it. Wax cell sponge are prohibited. You will be tracting vitreous and creating a bigger problem. This link takes you to a wonderful lecture of Dr. Steve Charles about how to deal and manage the vitreous. We use these studies to check the posterior pole, to make the IOL calculation, to check how's the support. But one important thing is, if you have a ruptured globe, an open globe, B-scan is prohibited. Coaxial, bimanual, Dr. Awad is there. Depends of the about the satisfaction of the surgeon or of the surgeon preferences. But I think that less than you open, less complications you will have. In kids, the size matters. This is a video of Dr. Megur, and you can see here a patient with a sonal dialysis. So the surgeon used staining, tryptan blue to stain the capsule. The surgeon used triamcinolone to stain the vitreous. Look at the stability of the chamber. He's using 23 gauge incision. And if you want, check the parameters as an initial setting up in your own clinics. Dr. McKeefe named this technique. This is a technique described by Dr. Ken Nischel. We can use this technique when we are working with traumatic cataract. The principle, he made 2 incisions. This original technique, he goes into the back. We can modify and apply the same principle that means push and pull. If the capsule is already violated, we can use this opening as a first hole and make another away and try to make push and pull. Never fight with the capsule. The place of the IOL is the back. But sometimes we don't have back. And one advice I can give you to you guys, fellows, this lecture is dedicated to you, is safety is first, above perfectionism. Perfectionism is right beside today, disaster. Do you have doubts about the capsular and the back integrity? Go to the sulcus. You go to the sulcus, use 3 pieces foldable IOL. First, place the IOL in the AC. Second, insert 1 optic and check it. Third, insert the optic and check it. Fourth, insert the second optic and check it. Avoid IOL rotations, and the most important, avoid IOL tannic. We're going to place the IOL. Well, aphakia is an embryogenic factor to be considered. Try to insert IOLs. If you suspect associated pathologies like endophthalmitis, corneal edema, poor visualization, intraocular foreign bodies, inflammation, delay the intraocular lens implantation for later. Here you can see a video of Dr. Kekuyana presenting about the secondary IOL implantation and anterior vitrectomy. And because we have a special guest today, I would like to share with you these references written by them about IOL in children, secondary glaucoma after cataract surgery, and one interesting video about traumatic cataract. You can ask them later their expert opinion. No capsular support. Partial capsular support. CTR is a choice. In the history of ophthalmology, we started with absolute contraindications for IOL implantation in children. Then contact lens appears as a choice. In the 70s, iris cloud IOLs appeared. Then sclerofixated, glue fixated. And now, the Hollywood star, Yamani technique. All these techniques has pros and cons. And I'm pretty sure that in the next future, we'll have new Hollywood stars. As I resume, the treatment and management of the traumatic cataract should be tailored. I hope that I could sell the traumatic lecture.